Recording. Welcome everyone to today's Let's Code Together session. Just a few housekeeping hours. So welcome formally to Let's Code Together today for the March session. My name's Jane Knight and I'm an instructor with the Medra MSSO, and I'll give you a wave for those of you joining us live. I'd also introduce my colleague, one of our medical officers, Dr. Caroline Wilson.
Hello, good morning. Welcome everybody.
Thank you, Kat. And together we're going to take you through the examples with your input for an hour and a half. So the first slide explains that Medra came about in the mid-1990s. It was an ICH initiative, and at the time the MSSO was put in place to maintain and distribute Medra. The activities of the MSSO are overseen by a management committee with representatives from across the ICH regions, both the industry and the regulatory authorities. The next slide is a disclaimer that the slides and the material today was the property of ICH. If you use anything or quote anything, you must acknowledge ICH as owners of Medra and of the material. At this point, I'll just comment, we don't make the slides available, but as I already mentioned, the recording will be put on the YouTube channel. We'd like you to participate in our examples as much as possible, and to do this you can use the questions panel to ask your questions or comment on the examples. Because there are so many of you, we can't take verbal questions, but you can write in your text questions. And if you're an expert on a particular topic, we can try to unmute you, but generally we prefer textual comments. We may not all agree on term selection. Sometimes in the interest of time, we have to agree to disagree, but we will address your comments as best we can in the time available. We can't take requests to code specific verbatims today in the session, but what we can do at the end, there will be a survey, and this was an option for you to propose new examples or topics that you'd like us to cover. But please make sure these are of general interest to the wider audience, not so specific that it's only of interest to your area of work. So this is how you do participate in the polls. The easiest way is to link via the QR code, and you can do that by scanning the QR code with using your smartphone. Alternatively, you can open an internet browser and you can type into the URL bar either on your phone or on your computer. Just type in polev.com as the URL, nothing more, just polev.com, just polev.com. And then you type in my name, Jane Knight 855, this is the username, and you click join. So if you forget those details, they're available in the chat, so you can go back to it, and I can show you this QR code at any time. So the first polling example here today, where are you joining from? Just check it's fully working. That's it, good to see. I can see some of you there from, lots across Europe, Spain stands out, North America again.
It's there, South Korea, Taiwan.
I think that's the
Russia,
Middle East, is that somewhere?
Middle East, India. Greece, I see Greece, Bulgaria, Spain, Portugal, lots in Europe.
Lots and lots of you. Welcome, wherever you are in the world.
Identified. England, Sweden.
Gosh, welcome, welcome.
Someone in the middle of the Indian Ocean.
Wonderful to have so many of you in such a global spread. It always makes me smile, at this point. So thank you for that. So here's the demo password for the web-based browser and a screenshot showing you, if you're not familiar, where you can access the browser. So take a screenshot of this, or Caroline's going to put it in the chat. There.
I did already.
Thank you, Caroline. Wonderful. So challenges in coding, there's not always an exact match, as I think we all realise. Sometimes there may be more than one possible approach. And even the points to consider document sometimes gives us options for handling terms. Sometimes we understand terms differently. Carol Ann and I find this when we're preparing the examples. We sometimes have a different interpretation in our head when we read the verbatim term. The best we can do is to represent events by a best approximation, but overall we always code as reported without making assumptions, without leaving out anything, but definitely without adding anything. And we always bring along a picture. This is the picture we've got today. And we say, well, you have to use judgment sometimes, because I might look at this picture and I see, yes, it's one of those optical illusions. It's a tree and it's got two faces down the trunk of the tree, a man and a woman facing each other. But when you look more closely, you see more in the tree. Look at the faces in the tree itself. And verbatim terms are very much like this. I can read a term quickly and immediately something comes to mind. I might have a picture of the patient in my head, but it's only when I look more closely or I speak to Carol Ann about one of the examples that we see there's more to it, and perhaps there's more lurking underneath, just as there are more faces in this tree than we first initially noticed. So overall, coding and medical judgment is a balance between applying rules so that we have consistency, but using that medical judgment to manage risks to patients. Medical references are often helpful in understanding reports, making decisions, not relying on your own background or knowledge. You'll see that in the examples today. Sometimes it's maybe even necessary to request a new term to be added to MEDRA if the reported concept is not in the terminology already, and we'll definitely see that today. So having said all of that, let's code together. And I'm going to turn my video off because it can be distracting. So just before we start, I want to follow up on something that came during the session. I say last month, I think it was January it was. So after consideration of some of the attendee comments, we'd like to update the suggested coding for one of the examples that we did discuss. So thank you for your participation. Thank you for your comments. It was definitely one of those examples like the tree, where as we looked again at the example together with your comment, that we've decided that yes, there was a valid point that you made, and we'd like to update our suggestion. So the term was biopsy of painful lump at the back of throat affecting swallowing, and we suggested that we would capture the pharyngeal mass and also pharyngeal biopsy, and that we would capture dysphagia because for the difficulty swallowing. But one of our attendees pointed out that it was also painful, and dysphagia, although in my head, again, without really fully referencing, dysphagia to me covered the pain. But when on further reflection, we decided that painful swallowing should also be added with the LLT of swallowing painful, with a different PT of odynophagia. So that was because dysphagia does not necessarily include painful swallowing, and so that's why we added that to it. So thank you for your input. It just shows we do follow up, and we're very grateful for your suggestions. So moving on then to today's material. The first example is non-alcoholic fatty liver due to metabolic syndrome. And Caroline's going to put it in the chat if you need to refer to it. So our first question here I'd ask myself is, well, what's this metabolic syndrome? I haven't necessarily heard of this before. Is it actually a medically valid thing, or is it something vague that we can't actually define? Are the two conditions related would be my next question, because when we're thinking of coding, is there a relationship between them, or do we need to split code? And whether we code it as one or two events, what would be the most appropriate LLT or LLTs? So going to a medical reference like Dorland's Medical Dictionary. There are multiple dictionaries out there, but Dorland's is the one that I tend to go to. So fatty liver, that's defined as a liver with fatty infiltration, fat in large droplets, and the liver is enlarged but of normal consistency. It can progress to hepatitis or cirrhosis if the underlying cause is not removed. And non-alcoholic steatohepatitis, so the fattiness there, steato, meaning the fatty non-alcoholic liver, is an inflammatory disease of the liver, uncertain pathogenesis, but histologically resembling alcoholic hepatitis. That's why it's called non-alcoholic fatty liver, steatohepatitis. And metabolic syndrome can also be referenced in Dorland's. That's reassuring. So it's a combination including at least 3 of the following. And then it's a question of, well, are these two related? So they mention here abdominal obesity, hypertriglyceridemia, with a low level of high density lipoproteins, hypertension, and a high fasting plasma glucose level. So both of the references mention a link to diabetes with metabolic syndrome and the fatty liver. But let's see, can we find it in medical references? Well, we found a reference in the Lancet that did link the two, non-alcoholic fatty liver disease as a cause and a possible consequence of metabolic syndrome. And it goes through there, again, some descriptions of the two conditions, a cluster of metabolic abnormalities that identifies people at risk of diabetes and cardiovascular disease, whereas non-alcoholic fatty liver disease is defined as a disorder with excessive fat in the liver, which we've already seen in our Dorland's definitions. So there is a link between them. That's what I wanted to check when I'm first deciding whether I can code it or I need to split it. That's the main question when I see this term. So having seen that, the relationship between them, how would you code non-alcoholic fatty liver due to metabolic syndrome? Would you code non-alcoholic fatty liver, metabolic syndrome? Would you select both of those LLTs, or would you seek clarification from the reporter, either for more information or to split? What would you do? I see the numbers going up as you're voting there. Right, so I think it's slowing down. Let me show you where your votes are so far. Most of you there, 77% of you would code both non-alcoholic fatty liver and metabolic syndrome. A few of you would code, but generally most of you would split code and select 2 LLTs. So that's the final vote. We'll stick with that. 76% of you would do that. So I think in this one, because the two conditions are straightforward, we can see that they both exist in MEDRA with the exact reported words. I'm going to skip the browsing in the interest of time today, and I will go to the learning points. So yes, you're right. We would firstly ensure that the syndrome is a valid medical concept, which we did both with Dorland's definition and with the article from the Lancet. We would understand the relationship between the two reported conditions, because as we know, we would ask for a split, or we would clarify if the two conditions weren't related. And then we would select 2 LLTs, just as you said you would do in the poll. When we do this, when one is a consequence of the other, not a symptom, and you'll be familiar with this guidance from the MEDRA term selection points to consider that if one is a symptom of the other, we don't need to split code. That's the preferred approach, to just code the diagnosis. But here one is definitely a consequence, so we code 2 LLTs. And that's the main learning point, I think, from this example. So we would select non-alcoholic fatty liver and metabolic syndrome for this one. Carol-Ann, do we have any comments so far on this example or on the previous?
Yes, several of our attendees suggested to code to LLT metabolic associated fatty liver disease. So this is an LLT under non-alcoholic fatty liver.
We could do that because it captures the metabolic element of it. But I think because my wording, if I have the option to split, because it specifically mentions metabolic syndrome, which we've defined as being a clinical entity in its own right, I think if I had the option to split, I would prefer to split code. So if I had that option, what you've suggested is a good alternative if we're in a situation of not being able to split code. That would be my take on that one. What do you think, Carol-Ann?
Yeah, I would split code because metabolic syndrome is a diagnosis itself.
Yes.
It's a defined medical concept. So it's not just a description of a metabolic abnormality, a vague description of a metabolic abnormality, but it's really a medical condition.
Yes, that's my thinking too. So thank you for your comments, but that's our rationale for the approach we've taken. So how to code? This is one which we've been asked a number of times. It's a question that does come in from time to time in training sessions or through the help desk, as well as in this session. It's one that came as a request that we cover. What is being reported here? Well, cause of death and its progression of disease. Does this refer to a pre-existing disease? It doesn't tell us what the disease is, but is there some way we would know that? Has the disease already been captured? Well, this is difficult to know just on the basis, coding out of context with the verbatim we have here. And then the fact that it's a cause of death, is death relevant to the coding? Is that something we need to capture? And overall, again, what's the most appropriate LLT or LLTs? So here's a free text question for you now, doing the polling. How would you handle the report, cause of death, progression of disease? What would you do with this report if you received it? Disease progression. So I see a number of you have already identified that there is an LLT of disease progression. Disease progression and death. Now, we've got a difference of opinion here. Do we code death? Or some of you are saying you would code it as with an outcome being fatal on the form, so you wouldn't code death. That seems to be the main option, the main choice here. And some of you would select disease progression NOS, although it doesn't say NOS in the report. The disease isn't specified. Somebody would try to get more information, so to clarify it. And somebody else now is giving us this suggestion. You would check if the disease has been recorded and coded, but we don't really know the disease, do we? It's all just reported as cause of death. So that's another thought. So thank you for your input there, all of you. A number of suggestions we've had there. And you see how a term can have different ways of handling it, even when it looks fairly straightforward. So that turning first to the MEDRA term selection points to consider, it tells us that if you have a report where there is a pre-existing condition that's changed, this may be considered an adverse reaction, or here it was a cause of death, especially if the disease is worsened or progressed. And we see some of the modifiers that may be reported, aggravated, exacerbated, or worsened, are all used interchangeably in MEDRA. Recurrent is a different qualifier. With that one it's not used as a synonym with the others. And progressive also is different. It's a different medical concept from the aggravation. So we always want to make sure we're looking for a progression of disease when we're looking for that. So it says that we should, if we firstly should look for a combination term which captures the modification of the disease. And the example here we see with exacerbation of myasthenia gravis, we look for an aggravated term, as I say, using exacerbated and aggravated interchangeably. So we would look for a progression of the disease, but we don't know what the disease is. So if we knew what it was, we could look for a combination term. If not, there are two suggested approaches. One is to select the term for the pre-existing condition and record the modification in some consistent documented way. This would depend on your processes and your coding conventions, also the purpose for which you're coding. Then the second approach would be to select a term both for the pre-existing condition and a second term for the modification of the condition, like disease progression. But again, we don't know the disease, do we? So remember, the condition referred to needs to be clearly and consistently identified, but not assumed. And that, I think, is where we come to about making assumptions. We don't want to make any assumptions when we code. And this is, sometimes we may have coding conventions so that if we are making judgments, we're doing it in a consistent way, but we don't make assumptions on a case-by-case basis. So I'll go now to the Medra browser. I'll open it from the web page, just as you would do using the demo password that we've given you today. So disease progression is what we're looking for. Let's see what we have. Disease progression, see what comes up. Disease progression, well, we've got disease progression. We've got a couple of specific progression terms that go with things like HIV disease or Alzheimer's disease, but there is the term disease progression and the LLT disease progression NOS. Well, I think at this point, I'll for my own coding practices, I don't code NOS unless it actually says unspecified or NOS in the verbatim term. We generally regard it as good practice to only code what's reported. So of those two, I would prefer the LLT disease progression. So I can have a look, go to the browser here and see if there are any other terms around it. There's disease progression there with the LLTs underneath it. Nothing else more specific. That's the exact wording we've been given. There's nothing with a death term that would be relevant to there, that they died. All the death terms are captured together in the general disorders. Here it is, fatal outcomes. I could have a look for the death terms to check that there's no death due to disease progression. Well, Medra doesn't really like due to terms, so I would look through these and there's none there. There's nothing there that captures death due to disease progression. So in that case, I would code the cause of death as disease progression. I would try to find out if there is, from the reporter, is there more information? Can we know the type of disease? And I would look for a specific term, if there was, which captured the name of the condition with progression, if I knew the disease. But without knowing it, there's nothing we can look for today. I can see and I can show you that there are a number of diseases in Medra which have a progression term, a progression LLT associated with it, like we could see, and that they only ever exist at the LLT. The PT is always the name of the condition itself. So that shows that it is useful to try to find out the name of the condition. So there's no, and then we would also consider in terms of the death qualifier, we would also know that death there, not qualifier, but the fact the patient died, that is captured as an outcome. As a number of you said, we always capture death as an outcome in the form. And if we know the cause of death, we don't need to code death itself. We code the cause of death. So here I would check firstly for internal company coding conventions. Maybe the disease refers to the indication. Maybe we could know that and we might have a coding convention. Sometimes this happens in oncology studies or a disease where the patients, there's a high probability that the patients will die during the trial. So it may be that disease progression, and there may have been guidance given to the clinical trial investigator sites around this on how to report the progression of disease as the cause of death. So check that, know how you're coding, know the situation if you can, look at the context of it. And then you would code the progression of disease. If you know the type of disease, you might capture that as well. Check if it has been captured. If not, you try to code it. Check for a combination term in Medra. And remember that the cause of death is not coded if we know the disease name itself. So we would seek clarification, check company conventions, and we would then select the LLT disease progression. We would select the Medra term to capture the name of the condition, or split code. Those are the two options, either coding disease progression and capturing the name of the disease if you know it. But as I've mentioned, don't code death if you know the cause. So that's what we would do with that one. I know that I haven't given you a black and white. You need to know what's going on. Is it a trial? And is there guidance around the reporting and the coding of these examples? Any comments, Caroline, or anything you'd like to add on your experience of these terms, or any comments from our audience today?
Yeah, there's a comment so that from the pharmacovigilance perspective, you would try to find out what kind of disease it was that progressed, of course, if you don't have this information in the case narrative. And then there's another, so it's just a confirmation what you just stated. And I would definitely also, I'm fully in line with you that there is no clear-cut answer to this question, because it really depends on the area where you're working. If you're working in clinical trials, then usually investigators enter progression of disease for the indication of the study, for the indication for use. And in PV, in pharmacovigilance, it may be different. So there you may have to query in order to find out, or look into the narrative again in order to find out what the actual underlying disease was.
Thank you, Caroline. Thank you.
And then there's another question from an attendee. In case for the term where an aggravation or worsening is not available in MEDRA, what would be your suggestion? If a disease is mentioned with an aggravation or worsening or whatsoever, and if this such a combination term is not available, what would be your suggestion for coding?
Well, I would code the name of the disease itself, because when you look in the hierarchy of those aggravated or exacerbated terms, the aggravation or exacerbation is lost at the PT level. So when you do select a combination term with the aggravated or exacerbated qualifier at the LLT level, when you come to do analysis, you're only capturing the disease itself, because of the PT is the plain disease. So I would code it to the name of the disease. There is an LLT for condition aggravated. So if you want, you can split code. But if you need to know that your own internal processes can link those two together. So in pharmacovigilance, that's probably easier to do than in a clinical trial setting. But because there's no point just coding condition aggravated and putting that in your database unless it's clearly associated with the name of the disease itself.
Yeah, fully agree. And I think it's even mentioned in the points to consider document for MEDRA term selection.
Yes.
Yeah.
The points to consider document talks about if the disease is pre-existing and it's already coded, it may be that a new symptom or a progression has happened and you want to capture the progression, and that's fine, but you need to realize, confirm that you have actually captured the disease and that it's clear the data that's being captured.
Yeah, and also you usually, the severity of the condition is captured in separate database fields that are also relevant for analysis purposes. So an aggravation would also be reflected in these fields where an adverse event or an adverse drug reaction aggravates from mild to moderate or moderate to severe.
Mm-hmm. If it's the name of the trial, the name of the indication, either for the drug or for the trial, then when it's reported as an adverse event and it appears in analysis, then it's fairly clear that that would be due to an aggravation, although you're not seeing the word aggravated at the PT level in the analysis. Mm-hmm. So thank you for your input on that one. Thank you, Caroline. I'll do my last example before I hand over to you now. This last example is one that was requested following one of our earlier sessions a few months ago now, not just recently. We've had it on our list for a while, so don't be despondent if we don't get back to you straight away in the next session. We sometimes hold on to the terms until we can research them or we can group them with other related terms. So the example that was requested was paraduodenal hernia. What does paraduodenal mean is the first question that crosses my mind. Where's the site of this hernia? And what's the most appropriate LLT for this? Is there something in MEDRA to capture it even? So looking in Dorland's, paraduodenal hernia is an internal hernia, so it's not protruding through the abdominal wall. It's within the abdominal cavity, in which there is abnormal rotation of the midgut during development, resulting in herniation of the small intestine behind the mesocolon. It's also called a mesocolic hernia. And just in case you're not familiar, an internal hernia, as I mentioned, is one that's a protrusion within the abdominal cavity to another abdominal compartment. So it's internal to the abdomen itself, not through the wall. A paraduodenal hernia on another site, I've given you the reference there from Radiopedia. This one splits it out into left and right paraduodenal hernias, the more common being the left side, 75%, and it tells you where the small bowel herniates here. And then the right side is through the bowel herniates through into a different area of the abdomen. So we won't go into the details, just be aware there are two types. So how would you code this? Is it a congenital hernia? We saw in the definition that it's something that happens during development. So is it congenital? Is it intestinal malrotation? Is it an internal hernia, a congenital abdominal hernia, or a congenital intestinal malformation? I find this quite a hard poll, I must say. I've worked on this example for a couple of sessions now, and I still find this quite a hard poll. So see what you make of it. And we had quite a long discussion, didn't we, Carol Ann, when we were preparing for this one for the last session? Yes. So if it was your example, you can always let us know. If you're on the call, let us know, send us a comment to let us know it was your example. It'd be nice to know that we have the requester with us. It's always lovely to see the same names in the list session by session. I know we've got quite a few of you take the time out to join us regularly, and we really do appreciate that. So how are we doing? I see we've got in the 60s now, around 60 of you have voted, going up slowly. Let's have a look at where the votes are sitting so far. It is a hard one. This is why we send the verbatims out in advance, so you've got a bit of time to try to sign up early for these Let's Code sessions, because we send the verbatims out a week before, or sometimes 6 days before the webinar. So most of you are looking at internal hernia. Few of you have coded for a congenital hernia or a congenital abdominal hernia, and then a few of you have gone for the other intestinal terms. So I think a lot of it hinges on what we saw when we were defining it, looking at the definitions of the hernia, that it is an internal hernia, but remember we need to check the hierarchy. And the question I would be asking myself is a paraduodenal hernia always congenital? And what we saw in the definition, you'll remember, is that it happens during development. So if it happens during development, and if that's the case in all cases, then congenital would be the most likely context, the most likely situation. And when something is congenital, we should always code it into the congenital sock. So when I do my browsing now, I'm going to be looking in the congenital sock. So although it is an internal hernia, and a lot of you chose this option, the difficulty with the internal hernia is it doesn't fall into the sock of congenital familial and genetic disorders, this one here. So I'm going to do my search, and I'm going to limit to that, and I'm going to search now for, I could search for a type of abdominal hernia, I could limit my search, or I could go to the congenital familial and genetic disorder sock, and I could open top down. So I could search in either way, searching for hernia here, in congenital, searching for an abdominal, intestinal, or paraduodenal should probably be our first search. Paraduodenal hernia. Is there anything? No, there's nothing listed with the word paraduodenal. So I could either do a search by limiting to the congenital sock, or I can look down, congenital disorders, top down, open gastrointestinal disorders, congenital. Look there, what have I got? Intestinal disorders, congenital is what we've got here. We've got some congenital intestinal malformation. That's the term I gave you in the multiple choice. so we've got some intestinal problems, or the other HLT we could look at as gastrointestinal tract disorders. I'm looking for some kind of hernia. Here's the congenital abdominal hernia. But the thing with the abdominal hernia is an abdominal hernia I generally think of as one that protrudes through the abdominal wall. And we know that it's internal. So just as a number of you chose internal hernia, but we don't have a congenital internal hernia. We have a hernia congenital here. So we have a congenital hernia, which is in the gastrointestinal tract disorders, HLT. So that's an option for me. Or there is the congenital abdominal, but my feeling on this one is this suggests it's protruding through the abdominal wall, but we're still not able to actually capture the disease, it's the condition itself, other than the congenital intestinal malformation. But the intestine isn't malformed, it's just that it's protruding. So none of these are really ideal for what we've seen. None of those in the multiple choice are ideal. So this is when I can't find the concept. This is when I start thinking about perhaps it would be a good idea to request this as a new term. So at this stage, I'd be looking for the closest hernia term that is congenital, because I know that it's a congenital disorder. So as a learning point, I would firstly reference the reported event, in particular looking, is it always congenital or predominantly congenital, which I'm happy that it is. So I would then look for an LLT or PT within that SOC. Select a term to capture the development or the manifestation of the hernia, and then consider submitting a change request for addition of this concept, because I don't feel the concept is really adequately reported. Abdominal hernia is one that I would, congenital abdominal hernia is one that I would consider, but as I say, I have this doubt around the abdominal section because it's internal. And then otherwise it's congenital hernia, but that's quite vague, even though it's in the GI, gastrointestinal HLT. So I did request, as part of the preparation for the session, I did request a new PT to be added. So that this is what the web CR form looks like. And if you don't use this regularly, I would suggest it's very easy to use. This shows you how easy it is using drop-down boxes that you can fill out, that you enter the term you want, and if you want, you can suggest the placement, but you don't have to. As you see here, the placement is optional. This is what I then received as a final disposition report, and this shows you what happens when you do request it. You get an email from us within 7 to 10 days telling you here what's happened. Here we see that it has been, it's a bit small to read, so I've put it here on another slide. Our suggestion was approved as requested, and the new PT of paraduodenal hernia has been added to the primary HLT of intestinal disorders congenital. So we've got a new PT for it, exactly the concept that has been reported. And you see here that the advice, the definition, if you like, or the guidance that that comes from our team of international medical officers tells us a little about the condition. This shows you from the supplemental view of the web-based browser. We see there the term has been added, and I've put this slide in just to show you the placement of it. It's been added to the HLT intestinal disorders congenital. That's the primary location of it. It also has a secondary link into the abdominal hernias not elsewhere classified group within the GI SOC, but the primary is congenital because, as we saw, it is a congenital disorder. So you can get this sort of view from if you change your web-based browser to supplemental view. So finally, the LLT PT I selected there would be congenital hernia on balance, but I know that this is only a temporary placeholder for the term, and when version 26.1 is released in September, then I would upversion it to the newly added LLT and PT paraduodenal hernia. Wow, that was a bit of a mouthful on that one, Carol Ann. Any questions or comments? I hope I haven't gone too fast for everyone.
Yes, we have some comments questioning the fact that we are looking for a term in the congenital SOC, but I think that the definition made it clear that this is a congenital condition.
Yes, there are some references. You can spend some time looking yourself, and it's congenital condition, and the highest incidence of it would be congenital. So if there was some unusual situation where it wasn't congenital, it still is predominantly, the highest likelihood is that it would be a congenital. So it tells us there that it's during development, it happens during development, and that we had a number of references. That we chose these because they were the best, we thought. So we see here the left paraduodenal hernia and the right, both of them say it's a congenital failure of fusion of the mesentery there. That's why the bowel can protrude. So that was why I based it on looking for congenital. And that's supported by, if you have a look, our colleagues, when they added the term, they added it to the congenital disorders SOC, and that supports our own interpretation or our own understanding of the report. Okay, I'm going to hand over to you, Caroline, if there are no more comments on that one for your section of examples.
Yes, there are no more comments.
Thank you very much.
Let me change presenter. Here we are. Do you see it, Jane?
Yes, that's perfect, Caroline. Thank you.
Perfect, thank you. So next exercise, a burning sensation is reported, and this burning sensation occurs immediately after a cream was administered to the chest of the patient. So what is being reported here? Is this clear? Is it unambiguous? Is the burning sensation related to the cream? And what would be the most appropriate LLT for this verbatim? Your turn again. Application site burning. Application site burning. Application site irritation. So the majority seems to vote for application site burning. Somebody would keep it more vague, just code burning. Allergic skin reaction would be a diagnosis. We don't know whether this was an allergic reaction. Maybe it's just the cream itself that causes some irritation at the skin. Yeah, some of you would code to application site burning, others would keep it more vague and just code to burning sensation of the skin. Administration site burning sensation is another suggestion. Okay, so thank you for joining. Thank you for participating in the poll, and let's check in the browser what kind of terms we have to capture such information. So the first thing I would do is to look into the general disorders SOC here, and here we have the administration site reactions. And when you look into these administration site reactions, you see that there are 6 HLTs underneath, and the first one is the one with the not elsewhere classified for, so grouping HLT, grouping all PTs that do not fit into any other of these administration site reactions. And you see that there's a lot of administration site PTs, very specific ones, also puncture site PTs. So puncture site could be used when a skin is punctured for biopsy purposes, or when it's not clear whether it was a vascular puncture or skin puncture. So this is again a quite vague term: puncture, puncture site discharge, puncture site inflammation. So vague terms here, and also vessel puncture site terms that you can choose from. So this is more specific. So this is not anymore a puncture site, but a vessel puncture site reaction. Then we have an HLT for application and installation site reactions. Again, many PTs to choose from, very specific for application sites and also for installation sites. And if I look for the MEDRA concept description of application site, you can see that for the purposes of MEDRA, an application site is considered to be the surface that contacts a topical medication in the form of a cream, like in our case here, lotion or patch. It does not pertain to other methods of drug delivery, such as injection or infusion by catheter or other means. So this really fits to our reported reaction. So let's look for such a term, application site and burn. Of course, I would also find burn. You always have to distinguish burn from burning, of course. There are chemical burns, thermal burns, but here what is reported is a burning sensation. So application site burning would be the best match here, and it is grouped under application site pain. Here we are. So what else do we have in SOC general? If I look into the SOC, we also have some terms in HLGT that relates to complications associated with device. And if I look into this HLGT, you'll see that there are two HLTs, complications associated with device NEC again, and vascular complications associated with device. So under this HLT, you'll find all the medical device site reactions, like medical device site pain, cyst, discharge, whatsoever. Lots of them again. And under vascular complications associated with device, here you find other terms like vascular access complication. Again, it's not including the information that this is a local reaction at the access site, but it's a really vague term that can be used for any unspecified complication after a vascular access procedure. And then we have vascular access site terms, again, very specific ones under this HLT. And when you look into the hierarchy here, you see that these are considered procedural complications. Vascular access site dissection, for instance, tests secondary linkages to general disorder SOC and to vascular, of course. So these are, you see that there's a broad range of terms that can be used for coding similar conditions. Here again, the concept description for application site and the screenshots of the hierarchy, of the relevant hierarchy for related terms. So here the administration site reactions, here we have the vascular access site reactions and the medical device site reactions. So what are our learning points? When receiving verbatims describing administration site reactions or vessel puncture site reactions, always make sure that the hierarchy of potentially suitable terms actually truly reflects the specific reported condition. So explore the hierarchy and select the appropriate HLT and PT for the specific reaction. And to help your coders deal with such verbatims, because you saw that there is a really broad range, many terms that are available in MEDRA for coding such conditions, consider to create and document coding conventions for this particular group of events to ensure accurate and consistent term selection for such reported conditions. And here it's quite easy. Burning sensation immediately after cream was administered to chest. We would code to application site burning under PT application site pain. Several of you have voted for a more general term like burning sensation of the skin. Yeah, it doesn't tell that it's really a local burning sensation at the chest after administering the cream to the chest, but it says immediately after the cream was administered to the chest. So I think that it's really possible to say that this is a local reaction. It's not an allergic reaction, because this would really take some time to have a more systemic reaction to this cream. It's occurring immediately after administration of the cream, and that's why I think it's a valid assumption, a valid approximation to say that this is really an application site burning and not a more systemic reaction. Other questions, Jane?
Yes, Caroline, we've got a few comments. So firstly, about the, are we making an assumption that the burning sensation is happening at the site? So we've taken it, haven't we, that the burning sensation is at the chest, but is that an assumption?
Yeah, that's why I just what I explained, because it's occurring immediately, it's taken place immediately after the administration. I would consider this a local reaction, because any more systemic reaction would manifest later.
And then we've had a couple of comments about, well, if it was an injection, you wouldn't necessarily say that it was. So I think you've addressed that as well, haven't you? If it was an injection, would it be different?
It would be different, yes. But here it's really an application of a cream. It's a local administration on the skin of the chest, and then immediately after this administration, a burning sensation is reported. So that's why I would go to application site burning in this instance.
And the fact that the chest isn't relevant, we're not looking for any term to capture any problem with the chest, are we?
No, this would suggest something different, like chest discomfort or so, some cardiac or pulmonary conditions.
And then the other question we have is, could you clarify the difference between application site burn and application site burning?
Yeah, this is very, very important to distinguish, because burn is really a thermal burn. So it's a thermal injury after contact with hot water or fire whatsoever. Whereas the burning sensation is just, so to say, paresthesia. So a local nervous system reaction here at the site.
Yes.
So burn, there's also chemical burn. Chemical burn can also be reported for patches or so combination products, patch with drugs, or when you have like I don't know, like patches, then you have then it's something that really irritates the skin in the cream or in the patch or in the lotion, something that irritates the skin in terms of the chemical, based on the chemical composition of the medicinal product. So this would be a chemical burn then.
Thank you.
And this would mean an injury as well, like a thermal burn. It would really mean an injury, like vesicles, some reaction in the skin that really represents an injury of the skin.
Yes, there's something to see, isn't there, on the skin?
Yeah.
Martin's suggesting iodine might fall into that category.
Mm-hmm.
Thank you for that. Thank you for your comments and questions. I think that's all, Caroline.
Okay, then I continue. And in our next example, a difficulty finding the vein is reported. So when looking at this verbatim, is it clear? Do we understand what is being reported? Does it represent a vascular disorder, or rather a procedural complication? Or could it be an administration error, a problem with the administration technique by a nurse or doctor trying to hit the vein? What is being reported here? Difficulty finding vein. So how would you approach this verbatim? Which LRT would you select? Difficulty finding vein, vascular access complication, vascular access site complication, poor venous access, vein collapse, wrong injection technique, product administration error. What would be your choice? Let's have a look what you're going for. Most of you are going for poor venous access, but we have a split of opinion here. Some of you would also are also voting for vascular access complication or vascular access site complication. Also vein collapse and wrong injection technique is disappearing. So let me close this and let us again check in the browser. So vascular access site complication. We saw these terms before when looking into SOC general. So let us check access complication and look into the hierarchy again. Here we are, access complication. If I click on it again, I see the hierarchy here. You see it's considered a procedural complication. It's grouped in the primary SOC injury, poisoning, and procedural complications, and has a secondary linkage to general disorders. So this is really not what has been reported here. We don't know whether a complication took place at the access site because, the person who tried to find the vein didn't even hit the vein, so there was no complication at all. The vein was just not found. And the same holds true for vascular access site complication. It's grouped under, here it is. Let us search for it and again look into the hierarchy. Again, it's considered, it's under primary SOC procedural complications, has secondary linkages to both general and vascular disorders in this instance. So as mentioned before, our verbatim does not indicate a procedural complication at the venipuncture site. So it's not suitable because no venipuncture took place at all. Vein collapse was also an option. Let us check. A vein collapse, here we have it, same PT, and it's grouped under vascular disorders with a secondary linkage to the injury SOC. So vein collapse is a temporary condition, and it occurs during blood sampling when venous walls collapse due to excessive vacuum that is generated. So this can occur due to small vessel diameter, thin wall thickness, or any age-related venous wall properties. So again, coding to this LLT would be an interpretation. We would add information that wasn't actually reported. We need a more vague term, because vein collapse would mean that the vein was actually already hit. So we don't know that the vein wasn't found, so there was no venipuncture. Poor venous access was the other option, and most of you voted for this term. Oops. Here we are. Same PT, and when we look into the hierarchy, we see it's considered a vascular disorder. So in my view, this is a vague term that best represents the reported condition. It's the best approximation to what has been reported, the difficulty hitting the vein. And we even don't know whether this was for product administration purposes or for blood withdrawal purposes. And therefore, wrong injection technique would not be suitable either. Wrong injection technique. Here we are. And if I go to the browser in order to check the hierarchy, we see that we are in the medication era. Product use errors and issues NEC grouping now. And here we have the wrong technique in product usage process. Inappropriate cutting of transdermal delivery system, inappropriate chewing of medication. So this would not be suitable. We would assume that something was supposed to be injected into the vein. We don't know that. Venipuncture may have been planned for blood withdrawal purposes only. So, and product administration error was the last option in the poll. And here we are, product administration error. And it's again considered a medication error that takes place during administration of the drug. So again, venipuncture may have been planned for blood withdrawal purposes only, and we don't know. It would suppose that something was to be injected. And the last option in the poll was the product administration error was the last option that we had. But again, we don't know whether something went wrong here, whether a wrong technique was, it would be an assumption, whether a wrong technique was applied when trying to hit the vein. We don't know that. It would be an interpretation. We would add information to the verbatim when selecting such a term. So how is medication error defined? Just as a reminder, a medication error is any preventable event that may result in the improper use of a medication or harm to the patient while the medication is under the control of those involved in the medication process, meaning physicians, pharmacists, nurses, patients, consumers, or their families. And the second aspect that is highlighted in green is important to remember. These errors occur during product use in the medication process by healthcare provider, patient, or consumer. So really important to remember that. So what we have in our verbatim is not a medication error. We even don't know whether a medicinal product was to be administered. It could be that the venipuncture was intended for blood withdrawal purposes. So what are our learning points here? When searching for suitable terms, use synonyms or terms with similar meaning and explore the hierarchy. Be clear about what medical concepts are represented by the different terms, the difference between procedural complications, procedural site complications, medication errors, and vascular conditions in the patient. And when getting such vague term, do not assume a procedural complication or an error made by the HCP, nor the reason for the venipuncture, whether it was for product administration purposes or for blood sampling. We would select a vague term and code to LLT poor venous access, same PT. Of course, it's considered a vascular condition in the patient, but for practical reasons, this seems to be the best approximation, because this is what how you would describe the fact that you don't find a suitable vein in diabetic patients or drug abusers whatsoever. So it's really a vascular condition, either a rolling vein or an injured vein, or you even don't see the vein in obese patients, for instance. So this is what we would suggest as final suggestion for coding poor venous access. Any questions, Jane?
Yes, Caroline, there are some comments from a couple of our group today saying that, well, how do we know? Are we making an assumption there? And I think you just addressed it by saying that, yes, this is how it's commonly reported when a nurse or healthcare professional has difficulty finding a vein. It generally means that that it doesn't mean that it's that they've been badly trained or they're not not working very well. But the comments are, is this an assumption? It might be that the healthcare professional isn't very well trained, or they're not doing it very well.
Yeah, I think it's a valid comment. So this was my my thinking as well, and we discussed this, Jane.
Yes,
but
we did.
This is for practical reasons the what you would consider the most probable scenario is that you don't find a vein because you don't see it, they are too small whatsoever. If something is due to a poor technique, inappropriate training by the nurse or any healthcare professional, then it would be reported differently. Here it just stated the vein cannot be found. It's difficult to find this vein, and therefore I would rather assume a vascular condition.
I don't think it would be reported, would it? If somebody couldn't take blood, they'd find someone else to do it, or it would. I don't think it would be reported like that. But we did consider that. It's interesting that you've had the same thoughts as us.
Any more comments or questions?
Really, that's it. Martin's saying there's millions of those. I think he means these kind of reports. So yes.
Yes.
Yeah, but thank you. It's interesting. Your thoughts were along the same lines as us.
So next one. Here we now I'm looking at a narrative describing a number of events and related therapy, something that you would see in case processing and drug safety and not in clinical trials. So here it is reported that a patient with pain in leg was diagnosed with embolic closure of the left arteria iliaca communis, the right arteria iliaca externa, and the arteria poplitea. And this was diagnosed via CT-Angiography. And the patient was then treated with embolectomy and stent PTA. So what information needs to be extracted here and finally coded, of course, when looking at this narrative? Is there information that needs clarification? For example, is PTA an unambiguous abbreviation? What do you think? So what needs to be captured? What information would you consider for coding? So please click on all options that are relevant from your point of view. Pain in leg. Nobody is, now we have, yeah. You are voting for all this information so that everything that is reported in our narrative needs to be captured. Again, thank you for joining. Lots of responses here. And here's a summary table. So what did we get? We got a symptom in the patient. It was the pain in the leg. Then the patient underwent an investigation, diagnostic procedure, CT-Angiography needs to be captured as well in the case report. Then we have, based on this diagnostic procedure, we got 3 diagnoses. We got embolic closures of the left arteria iliaca communis, the right externa, and an embolic closure of the arteria poplitea. And at the end, the patient was treated with an embolectomy, stent, and a PTA. So please note that when split coding, some context may have to be preserved, meaning that the original wording may have to be adapted. First of all, a stent was reported. You won't find an LLT stent in MEDRA because a stent is a specific device and MEDRA is not a drug or device dictionary. So you would search for stent insertion or similar. And extraction of stent insertion would be too vague because we know from the narrative that this was a vascular and arterial stent insertion, not an ureteral or intestinal stent. And PTA is an ambiguous abbreviation. Yeah? But in the context with the stent insertion, the arterial stent insertion, we can assume that this is the abbreviation for percutaneous transluminal angioplasty. So the context makes it an unambiguous abbreviation. So there was one question mark here in our table, as you see, whether coding is required for the symptom. And all other terms need to be extracted and coded, of course. And the reported pain in leg is, of course, a typical symptom of the arterial embolism. And the preferred option provided in the points to consider guidance document for MEDRA term selection specifies that when a single definite diagnosis is reported with related signs and symptoms, only the diagnosis has to be coded. And we always show the preferred option in our trainings. But alternatively, you may decide to code both the diagnosis and all reported signs and symptoms. You see the alternate solution here. So it's your decision, but your decision should be documented in your internal coding conventions, and it should be consistently applied to all such scenarios. In our case, embolism was diagnosed at 3 different locations. And the PTC document provides guidance for such coding scenarios as well. We are told that if an event is reported to occur at more than one body site, and if all of those LLTs link to the same PT, then select a single LLT that most accurately reflects the event. In other words, the event information has priority. And there's one example here: skin rash on face and neck would be coded to skin rash because rash on face, neck rash, and skin rash, all 3 LLTs link to PT rash. Edema of hands and feet is grouped under, should be coded to edema of extremities because edema hands and edematous feet both link to PT edema peripheral. However, the LLT edema of extremities most accurately reflects the event in a single term. So you should not always select the LLT that is identical to the PT, but really look for an LLT that summarizes the reported conditions in the most specific way. And how would you prioritize embolisms versus occlusion? Because what was reported was an embolic closure, an embolic occlusion of these arteries. Or would we split code? The definition of embolism in Dorlins helps us decide what to do. Because embolism is a sudden blocking of an artery by a clot or foreign material that has been brought to its site of lodgement by the blood current. So the occlusion is an integral part of the embolism, and coding to an embolism term is the best choice because an arterial occlusion could be caused by other conditions as well, by thrombosis or external compression, meaning that when coding to a suitable embolism term, we would capture the pathomechanism, the arterial embolism, and the occlusion of the artery. Now, again, let's look for suitable terms in the browser. Oops, again. Here we are. The pain in leg is a direct hit in MEDRA. So this would be the symptom of the patient. And then by a diagnostic procedure, the diagnosis is made why this patient suffered pain in leg. As mentioned before, it's grouped under pain in extremity. Depending on your coding conventions, you can code pain in leg, but if you just take the preferred approach, that is recommended in the PTC document, then you could ignore this information and could just code to the subsequent diagnosis. So CT-Angiography was the diagnostic procedure that took place in order to make these diagnoses. Here we have the angiography. We go to the browser. And here is the CT-Angiography. Here it is. So again, a direct hit to MEDRA. Then we have the embolism. And if I enter embolism and iliaca and search, I won't find anything. As always, try to use word stems in order to capture embolism and embolus, for instance, and here in order to capture iliac or iliaca. So here we are. And here we have the iliac artery embolism or embolism. Let's check again the hierarchy, whether we find some more specific terms for it. No, we cannot differentiate here. There's only the iliac artery embolism that is available, or iliac artery embolus. So embolism was reported. This would be the best choice in our for our verbatim. Then we had the embolism of the poplitea. No, there's no hit. Let's look for embolism leg, for instance. Make it broader. Nothing. Again, let's use a word stem. Embol and leg. And here we have embolus leg. If I go to the browser again, we find embolus leg under the PT peripheral embolism. So it's separate from the iliac artery embolism. Here it is. So this would capture, these two PTs would capture the embolism in the patient. Now what about the surgical medical procedures? Let us look for, restrict our search to the surgical medical procedures SOC and look for embolectomy. Let's see what we get. Aneurysm embolectomy, here it is. Femoral embolectomy. Let us go to the browser. Here we have the embolectomy. Arterial embolectomy would be the most specific term that we can find, because we know that it was an artery, but it doesn't matter because an embolectomy only, it's all grouped under the same PT, thromboembolectomy. So arterial embolectomy would be the best choice. And now, what about the stent? I mentioned before, there is no stent term in MEDRA, so no direct hit, exact match here. But if we look for stent insertion and search, then we will find several hits. We find the arterial stent insertion. This sounds promising already. And you see there's a bile duct stent insertion, double J stent insertion, gastric stent insertion, esophageal stent insertion. And here we even have a more specific term, peripheral artery stent insertion, grouped under the same PT. Let's go to the browser, see whether we find some more specific LLTs underneath. Here we have the peripheral artery stent insertion, femoral-popliteal artery prosthesis insertion, iliac artery stent insertion, peripheral artery stent insertion. So all of these are grouped under the same PT, peripheral artery stent insertion. Then PTA needs to be captured. And because PTA is an ambiguous abbreviation, you won't find any hit in MEDRA, nothing. So let's spell it out. And then we will find percutaneous transluminal angioplasty. Here we are. And it's also grouped under the surgical sock. Here we are. So you may ask yourself whether we have to assign both the stent insertion, the peripheral artery stent insertion, plus the PTA. First of all, it is not made clear by the report whether all emboli were treated the same way in all 3 locations. Also, one could argue that a stent insertion into a peripheral artery always requires a PTA, so that no split coding would be necessary and only the arterial stent insertion would have to be captured. But this would not be okay because direct stenting without predilatation with PTA is also an accepted surgical approach for such conditions. So both need to be extracted and coded. So what are the takeaways here? In pharmacovigilance, complete and medically accurate term extraction is key. High quality coding cannot compensate for incomplete or incorrect term extraction. All relevant medical information of the case narrative has to be entered into the data elements of the individual case safety report according to the ICH E2B standards. And as always, the guidance in the PTC document must be followed, and when searching for suitable terms, make use of the MEDRA hierarchy and the features of the MEDRA browser to find the most specific and accurate MEDRA terms that reflect what has been reported in a medically meaningful way. So here are our final suggestions. We would code the reported adverse events in the patient to embolus leg under PT peripheral embolism and LLT and PT iliac artery embolism, because there are no more specific terms for the embolism of the arteria iliaca, communis, and externa. The pain in leg, this depends whether you take the preferred approach or the alternate approach that is provided in the PTC guidance document. You may code it, but if you take the preferred option, you can omit this information because you have captured the diagnosis already. Then you would, of course, code to the CT-Angiography. This investigation needs to be coded in addition and entered into the respective field in the E2B report. And last but not least, the treatments need to be coded with arterial embolectomy under PT tromb embolectomy and percutaneous transluminal angioplasty under angioplasty and LLT and PT peripheral artery stent insertion. Any questions, Jane, or comments?
Yeah, we've got some suggestions of alternate terms, Carol-Ann. So
yeah.
Ischemic limb pain instead of leg pain.
Yeah, you could use it. It was not reported. Yeah, it was not reported. It's a, I think so. Yes, you could do so if you have everything in context. If you're coding out of context, you could not assume that this pain in leg was an ischemic leg pain. If you see the full narrative and you are coding in context, then you could assume that this is ischemic leg pain due to the subsequent diagnosis, of course. Yes, but if you're coding out of context, you couldn't do so.
Okay, the next suggestion is popliteal occlusion or thrombosis, but thrombosis isn't mentioned, it's embolus, but popliteal occlusion. Yes,
this is what I mentioned before, that embolism, the pathomechanism of the occlusion was an embolism, and the occlusion of an artery could occur due to external compression, thrombosis, not only embolism, and that's why embolism is the most specific medical information you need to capture. And as I've shown in the definition of Dorland's, the embolism includes the occlusion of the affected artery. So it would be no split coding is needed. Embolism includes the information that this artery was occluded by the embolus.
Yes, thank you. Sorry, I missed you covered that bit already. Sorry. Embolism arterial limb instead of embolus leg. Well, embolus, so getting the artery, you've split coded them.
Yes, I considered it. Limb could also refer to the arm, so we know that the leg is affected. So I considered this as more specific than just coding it to a limb term.
And you've got the correct artery, haven't you? And then stent placement and stent insertion are just synonyms, aren't they? Is another question.
Yes, they are synonyms. That's why I said you need to look for a stent term that includes the information insertion or similar. So placement is of course a synonym that you can use.
And then comment, is peripheral embolism not covering the iliac artery embolism? Well, again, iliac artery embolism is more specific, isn't it?
More specific. You should always code as specific as possible. And we have 3 diagnoses here, actually. We have one diagnosis for the popliteal artery, and we also have the diagnosis that 2 of the iliac arteries are affected by the embolism, and that's why this needs to be captured. And it's separate PTs. Whenever information that you receive can be coded to separate PTs, this needs to be done. So then split coding is required. Only if LLTs are really grouped under the same PT, you can summarize the information and just assign an LLT that is either identical to the PT or that somehow groups the information that you have received.
Okay, Caroline, I think that's everything then. Or let's have one more. Would you consider embolus lower extremity, because it doesn't actually say the embolism was in the leg, only that the pain was in the leg? Well, the iliac artery embolism, so it's suggesting that by choosing iliac artery embolism and embolus leg, you're saying that the embolus lower extremity, well, that is leg as well, isn't it? So it's no different.
It's a synonym. You could use as well. Yeah, sometimes for such you will never achieve 100% consistency, because they are really on the LLT level. You find not only quasi synonyms but really synonyms. So whether you code to embolus leg or embolus lower extremity is really the same, or lower limb.
Yeah, thank you. I think that's everything. You raised quite some questions and comments on that one, Caroline. Got everybody.
I expected that.
That's that one. So I see because that was a longer example, we've not covered quite as many this time, but that's because we covered so many all wrapped up in one there with that example. And that again is something people have asked us to do more like a narrative, bigger examples, more complex. So that's why we've done this example slightly differently, isn't it, today? but it does mean that we're out of time, and I think we should leave it there. It's 10:30 now. So if you agree, Carol Ann, I'll take it back and I'll cover our concluding slides. We've had a comment. Somebody asked us, could we send the answers to the examples we haven't done? I realise we've got 4 examples we haven't had time for today. Could we send them out by email? We don't send answers because, as you see, we have difference of opinion. Sometimes your comments actually make us take a second thought, and we don't send black and white answers out by email in the same way we don't share the slides. So what we'll do is we'll roll them over to the session in May. The session for May, I believe, is posted today. It's just available. So if you have got the day free, come along to join us in May. We'd love to see you. Get in quick because places are limited at this session. Sign up quickly. And then we'll do those 4 sessions definitely in May, those 4 examples, sorry, in May, and we'll find another 6 new examples. So in the survey, you'll see in a moment, you've got an opportunity to give us your suggestions for future sessions. And we've got some that people have given us already. So here is the YouTube playlist that you'll see. Oh, this is session 20 today that we've done. Carol Ann and I have been doing it since November 21. So we've got quite a number set up here. You can see them. You can follow them on the YouTube playlist for it if you want to look back. There's also an index on the training page where you can actually see interactive index, where you can see terms that are from a particular therapeutic area, and you can highlight which, help you identify which of the 20 sessions is most interesting to you on YouTube. So that's that one. The verbatims are listed against each of the sessions on YouTube. This is the survey I mentioned. You'll also get a SOGO survey, our standard webinar survey, after the session, but we like to have your feedback, if you can, as quickly as possible, and particularly when you're giving us ideas of topics or verbatims for next session. So we like to do an additional instant survey, and this is what I see a number of you are doing here. So that's the survey. I'll leave you filling that out. And then the last couple of slides we have just give you some links to the Medra Help Desk, the browsers that you've seen us use, the website. And then if you have terms that you need to request changes to Medra, the training schedule where you'll find the May session posted for sign up, and the link to the support documentation, including the points to consider documents that we've mentioned today. So that's all of the things we wanted to cover. Anything else to mention, Carol Ann? Oh, certificates. If you will be eligible for a certificate if you were here for the whole session. I mentioned it at the beginning, but if you were late joining us, it may be that then you weren't eligible for a certificate. We only make allowance of a few minutes for people if we overrun or if people have a bit of trouble joining. Otherwise, we expect you to be here for the whole session to get the certificate. Anything else to mention, Carol Ann, before we say goodbye?
Nothing from my end. All said.
Thank you, Carol Ann. Well, thank you for your collaboration on this. They're always fun sessions to do with you. And thank you, all of you, for your input today, you've obviously done pre-work on them, which we appreciate. And I hope to see you, as many of you as possible, in our session in May. So looking forward to that. And thank you so much. Stay safe, everyone. Enjoy the rest of your day.
Thank you, Jane. Thank you all. Hope to see you again. Bye-bye.
Bye-bye.